Thank you for coming today. I'm Dr. Alexander Gilbert. I'm the medical director at the MedStar Georgetown Transplant Institute, and I want to welcome you today to our presentation to learn about kidney and pancreas transplantation. What we're going to cover today is to go over the benefits of transplant, why people should be interested in transplant. We'll talk about the types of kidney transplants available. We'll talk about the transplant timeline and what you can expect to happen over the next few days, weeks, months, and years, and also answer any questions you may have, starting with some of the more common questions that we tend to get. The first question and most important question is why choose transplant? What are the benefits of transplant? What can you expect from transplant? The most important thing to know is that transplant is one of the few things in medicine that actually can extend life. This graph shows how long the average person can expect to live from a given age. The top line in blue is the general US population. The line in red is for patients on dialysis, and the green line is what happens when we transplant you. And the way you should look at this is to take an example. If you are 50 years old and on dialysis, the average lifespan is about another 7 years. Now, that's not to say that everybody will live 7 years or will live only 7 years, but the average is about 7 years. If you are 50-year-old and instead of staying on dialysis, you get a transplant, you now can expect on average to live 18 more years with the transplant. So transplant vastly extends your expected lifetime because it makes you healthier. It's a healthier option than dialysis. Dialysis is trying to cram 2 days worth of kidney function into a 3-hour session. Or in the case of peritoneal dialysis, where you're doing it at night, you're trying to cram an entire day's worth of kidney function into a few hours of dialysis time at night. Whereas when you get a kidney transplant, that kidney transplant is working 24 hours a day, 7 days a week, doesn't take off banker's holidays. This extension of life is somewhat age dependent. The younger you are, the greater the benefit. For a 30-year-old, for a 35-year-old, the benefits of transplant are absolutely enormous. It is true that as people get older, when people are considering transplant in their 70s, early to mid-70s, at that point we can't demonstrate an extension in life. But there can still be a potential advantage to transplant in terms of how it makes you feel. And the second important thing to know about transplant is that it does improve your quality of life. People have described increased physical activity, energy, mobility. They're not tied to a dialysis machine. They can travel more. They've really noted a number of benefits from them. And just so that you know, this is not a picture that we took out of a book somewhere, but this is actually a patient of mine who got transplanted at the age of 70, and this was him doing whitewater rafting at the age of 73. And to pick him out of the group, he's the one with the kind of funny looking smile. I still don't know if he's excited or absolutely terrified in this picture. But in fact, this is something that he never could have considered before he got a transplant. So let's talk about the types of transplants that are available to people. In general, transplant comes in 2 forms. You can get a living donor kidney, that is someone who is alive and donates one of their 2 kidneys to you. Or you can wait for a deceased donor kidney, someone who has died and has agreed to donate both of their kidneys after death. Between the 2, clearly the better option is the living donor kidney in a number of different ways. In the first place, the living donor kidney, because it's going right from one person to another very quickly, 95% or better function immediately without any sort of treatment afterwards. In fact, while we're still in the operating room, we can see the kidney functioning and making urine. In the case of deceased donor kidneys, while most of them work very well eventually, about a third of the time, because they've been through a shock of the donor dying and then being put on ice and then being retransplanted into the recipient, that is a shock to the kidney, and it can take some time for the kidney to kind of wake up and regain its function. And so about a third of the time, people do need some dialysis for days or weeks after the transplant before that kidney starts to function again. And again, even when you need dialysis, those kidneys do start to function and do very well but it's a little disconcerting for people to go through a transplant and then to find, at least for a short period of time, to be on dialysis. In terms of how long the kidney lasts, living donor kidneys do tend to last longer. The average, and I do want to stress the word average, this is not a limit to how long they can last, but the average lifespan for living donor kidneys is 15 to 20 years. For a deceased donor kidney, that same average lifespan is 10 to 12 years. But again, we've seen deceased donor kidneys that last 20, 25, 30 years. My personal record is 42 years for a deceased donor kidney. But again, on average, if you're saying what gives me the best chance for a long-lasting kidney, a living donor kidney is clearly better. In addition, and this is maybe the most important thing that we have to say about the living versus deceased donor kidneys, is that it is much faster to get a living donor kidney. If you have a living donor who steps up and says, I want to donate a kidney, and everything works out, we could be doing the transplant within months of the initial evaluation, as soon as everybody completes their testing. In the case of deceased donor kidneys, there are far more people waiting for kidneys than we have kidneys to give out. And so as a result, it may take years before you get to the top of the list, as we say, where you get offered a kidney. The final thing is that scheduling is a little bit easier. When you have a living donor kidney, we can schedule that whenever is convenient for both the patient and their donor. On the other hand, with deceased donor kidneys, it's whenever that organ becomes available. And if it becomes available at 2 in the morning, we will give you a call at 2 in the morning and say, come on into the hospital. It's a small thing, but it's one more thing to consider when you're considering options for donation. So let's talk a little bit more about living donation, which is clearly our best option. The donors that come in, if someone wants to donate a kidney, they have to pass their own medical and social evaluation to make sure that they are safe for donation. The last thing that we want to do is take someone and by taking their kidney to make them sick. It's important for you as recipients to realize donors live normal lives after donation. People who donate kidneys can engage in a normal range of physical activities. We have had people who are active duty military who stay active duty. We've had people who are police officers who remain fully functional in the field. We have people who do heavy lifting or very physically demanding jobs who continue to do them after donating a kidney. So there should be no change in physical activity after donating a kidney. People who donate a kidney can still have children. Women can bear children. It's not considered a high-risk pregnancy. People who donate kidneys have a normal life expectancy. No one is giving up any part of their life if they choose to be a living donor. Nor do those living donors require medication or any sort of special diet after they donate a kidney. They can literally go on with their lives just as they did before they donated the kidney. And then finally, it's also important to know that they are not at increased risk of diseases like high blood pressure or diabetes after donating a kidney. What else do you need to know about living donors? It's important to realize that the medical costs of donating a kidney, the surgery, the workup, the testing, that is all covered by the recipient's insurance. If you have private insurance, that generally covers the evaluation, the surgery, and that's very good. But if you have Medicare or can get Medicare as an insurance, that not only covers the evaluation and the surgery, but it also covers any post-surgical costs for 1 year after transplant, just in case there were complications. And so we strongly recommend that all recipients who are considering living donors should get Medicare as their primary insurance. Donors do not need to be a relative. They don't have to be closely related. They don't have to be of the same gender or the same ethnicity. They don't have to be of roughly the same shape, height, weight, or anything like that. Really what we're looking for primarily in our donors is a blood group match. But I wouldn't even bother asking your donors about that, because in the case where you may have a donor who is not of the appropriate blood group to donate to you, they can still get you a living donor kidney through our paired kidney exchange. And let's talk about that for a second. The paired kidney exchange is a swap of kidneys. And so what happens is if your donor can't donate a kidney to you, there may be someone at another center somewhere in this country who also has a donor who can't donate to them. But their donor may be able to donate to you, and your donor may be able to donate to their recipient. And in that way, both of you get a living donor kidney that happens to be compatible by blood group. Okay, and you can talk more about this with your team as you get into the room if you have specific questions. But this has become a very powerful tool for people to get compatible kidneys rather than getting a higher risk incompatible kidney. In addition, being part of the National Kidney Registry and the Paired Kidney Exchange provides other benefits. MedStar is a donor shield program, which means that our donors are eligible for the following benefits, including reimbursement of lost wages during their recovery, up to $1,500 a week. They are eligible for payment for travel and lodging reimbursement. They are able to get life insurance. They also have the ability to get disability insurance during the time of their donation. They also have free legal support in case there's any sort of issues over losing their job, which is not allowed to happen because of donation. And they're also allowed to cover uncovered donor complication costs. So if you don't have Medicare to cover those complication costs, there are still other ways to get those donor costs covered. If you do have or think you might have a living donor, the most important thing that you can do in your packet that we give you is to look for this pink card. On this pink card, it has on the front in English and on the back in Spanish, it has a website that your donor should go to where they will fill out a form, and that will start the process of their evaluation. And that can happen even before you complete your evaluation as a recipient. A couple of things to know about living donors. The donors have to contact us first. We are not allowed to reach out and call a living donor. None of us like getting calls to sell us stuff during dinner. Can you imagine getting a call, would you like to donate a kidney during dinner? So we don't reach out to them first, but once they reach out to us, once they fill out that questionnaire, we will then be in touch with them on a regular basis to go about their workup. Typically, a donor evaluation takes about 2 months. Some people have chosen to advertise on media, either on Facebook or somewhere else. If you decide to put up a post, which is perfectly acceptable, in fact, we encourage that, you should use yourself as a contact person. If you're looking for people to donate kidneys, you should not have your donors contact Georgetown directly. So they should contact you, and then you can give them our contact information, and we will speak with them. If you have any potential donors with you today, please talk to your coordinator, and we will start the application process today for their evaluation. For those who don't have living donors, there's always the deceased donor option, which, while it is not as good, is still a valid option. Unfortunately, as I mentioned before, the waiting time to get a deceased donor kidney can run long, and this often depends on your blood type. If you're lucky enough to be blood type AB, the wait is only 2 years, but you can see that blood group A is longer, but blood group B is longer, and blood group O is about the longest wait and can go as high as 8 years to get a kidney. There are some ways that you can shorten this wait for a transplant. The most important one that I want to talk about is accepting what we call non-standard organs that can help to reduce your wait time. What do I mean by a non-standard organ? You can accept an organ from an older donor, which we term the high KDPI. We'll talk about that in a second. You might be willing to accept a donor who is positive for the hepatitis C virus. Or if you are HIV positive, you may be willing to consider an organ from an HIV positive donor. When I talk about the KDPI, the Kidney Donor Profile Index, organ donors come in all different shapes and sizes. They're different ages, they're different weights, they're different heights, and they have different levels of health. Some may have some high blood pressure, some may have had a stroke, some may have had diabetes. And there is no absolute cutoff for accepting or declining an offer. They run on a scale of better and worse kidneys. The KDPI, this Kidney Donor Profile Index, weighs several different donor factors and puts them into a formula and comes up with a number from 1 to 100. Here's the key thing to remember. The lower the number, the better the kidney. Okay, so a KDPI 1 kidney is the best kidney out there, and a KDPI 100 kidney is not nearly as good, but still good enough to be transplanted. So a natural question is, why would I, as a recipient, accept a higher KDPI kidney? Why wouldn't I just wait? And the answer is that if you decide to only accept the low KDPI kidneys, there are a lot of people waiting for kidneys and only a small population of kidneys to be had, and that's going to extend the time that you wait. If, on the other hand, you broaden the search and you say, I will consider all the KDPIs, including the high KDPI kidneys, now you're picking from a much larger population of kidneys, and you can get a kidney much faster. And faster is also generally better. This is what happens generally to people who turn down high KDPI kidneys. This is actual data that was published recently. So these are people who said, I'm not going to accept a high KDPI kidney, a KDPI over 80. What happened to these patients? Some of them did well. 7% wound up getting a living donor, which we said that's a better kidney. 31% got a low KDPI kidney. So by holding out, they actually got a better kidney. There were some people who broke even. 6% of people, they turned down a high KDPI kidney, and in the end, they wound up getting a high KDPI kidney anyway. But the problem is that most of the patients wound up doing worse. 14% of them are still waiting for transplant. So they turn down a kidney, and they still stay on dialysis, so they haven't received that good offer yet. 20% got removed from the list, meaning they're not going to get a transplant because they've become too sick to get a transplant. So unfortunately, they waited, they passed on a kidney, and now they're not in a place where they can get a transplant. And the really bad news is that 21% of people who passed on a kidney that could have gotten them off dialysis then wound up dying before they ever got an offer that they did accept. And so in general, it is a much better idea to accept these high KDPI kidneys, come off dialysis, start feeling better, lengthen that expected lifespan. And if the kidney isn't doing as well as we want, we can talk about another transplant in the future if we need to, but a lot of these do very, very well. And so I urge you to consider these high KDPI kidneys as good alternatives. And what I say to the patients is, it's not a choice between a high KDPI kidney and a low KDPI kidney. If that were the case, I'd always say take the low kidney. What the choice is between getting a high KDPI kidney now or staying on dialysis and potentially never getting a kidney transplant. And that's why I say the high KDPIs are good alternatives. Another way that we can shorten your waiting times is if you're interested in accepting a hepatitis C positive kidneys. We offer these to people whether or not you as a patient have hepatitis C. And the reason that we do this is, again, it shortens your waiting time because we are expanding the pool of kidneys that you can get. And there is now a cure for hepatitis C. These are extremely successful agents. They've only been available since about 2015, but they are 99% effective. It's about an 8-week course. It's like taking an antibiotic for pneumonia. You take an antibiotic, in that case, for 2 weeks, and you clear the pneumonia. In this case, we give you a course of therapy for 8 weeks, which is very well tolerated, and you wind up cured of hepatitis C. But I do want to be clear that if you accept a hepatitis C positive organ, we expect that you will get hepatitis C, and then we will give you the medications to cure the virus post-transplant. And again, this is something that I want you to be aware of, but something that you should talk more in depth with your team today to learn more about. For those patients who are HIV positive, we can also offer HIV positive organs. This again significantly shortens waiting times because these are only going to patients who are HIV positive. And what we do in these cases is we look at the sensitivity of the virus in the donor, right, making sure that it's not resistant to the medications that you are currently using for your HIV, so that those same medications will control any transfer of the virus from the donor. We've done a number of these kidneys. We're part of a consortium of about 17 centers in the country that are doing these transplants, and the results have been excellent without any reactivation of virus after the transplant. A couple of final thoughts about whether to accept or not accept these non-standard donors. And I say, when in doubt, if you need time to think about it, say yes now. Nothing is permanent. You can always call us back and say, listen, I've thought about it and I don't want to do this. And that's okay. We're not going to be upset. We're not going to give you a hard time. We are absolutely happy if you change your mind later. In addition, when the organ actually comes up for an offer, you can always turn down the offer at that time. And let me be clear, when you turn it down, there is no penalty to you. We don't mark you down as someone who's doing a bad thing or who has, refused a kidney. We simply pass on you for that offer and we'll give you another offer down the road. So if you, for example, say, okay, I will accept a high KDPI kidney, I know it may be from an older donor, and you get a call and you say, I didn't expect it to be that old a donor. You can always turn down that kidney then. So saying yes now just keeps your options open. If you say no now, you'll never get called about that high KDPI kidney, and you'll miss out on a chance that maybe you would have accepted it. So that's why I say yes now, you can always say no later. I want to say a couple of words about those of you who are considering pancreas transplantation or who have diabetes. So pancreas transplantation is for patients with diabetes mellitus. It doesn't matter if you are type 1 or type 2, or even if your doctor says to you that they can't tell what type you are. The new pancreas that we give you will make insulin, and that's what is lacking in diabetes. It's a lack of insulin production. So by getting a pancreas transplant, you will make insulin, and you will no longer need either pills or insulin to control your diabetes. And that pancreas transplant can last for 10 and up to 20 years, and I've seen a few last even longer than that. The pancreas transplants, on average, actually go longer than the kidneys. Any pancreas transplant only comes from a deceased donor. We all have only one pancreas in our body as opposed to 2 kidneys, so you can't have a living donor donate a pancreas because they need it themselves. However, if you need both a kidney and a pancreas, you can still get the kidney from a living donor, and then we will later do the pancreas from a deceased donor. It is important to realize that for those considering a pancreas transplant, there are stricter criteria for a pancreas than for a kidney. So there are patients who we say are candidates for kidneys, but still are not good enough candidates to accept a pancreas. What's the good? What's the benefit of a pancreas transplant? Well, after a pancreas transplant, you will no longer need any medication for diabetes. We're not talking about reducing your insulin dose. We don't talk about reducing your oral hypoglycemics. We talk about getting rid of them entirely. The other nice thing is that the wait for a pancreas transplant is much shorter than that for the kidneys. We said that a kidney waiting time can go anywhere from 2 to 8 years, but the wait for a pancreas is only about 12 to 24 months, so under 2 years. Moreover, if you need a kidney and a pancreas, when you get offered the pancreas, you are also going to get offered a kidney from that same donor. And so it's a much shorter wait for a kidney if you're getting it with a pancreas than if you were just getting the kidney alone. The other thing is that pancreas donors really have to be very young and very fit. And so generally all of our pancreas donors are not overweight, and rarely are they above age 45. And so they represent the youngest and best of the deceased donors out there. And remember, you're not just getting the pancreas from that donor, you're also getting a very good kidney from that donor. So it's a really good way to get a kidney faster and to get a better than average kidney. We don't have high KDPI kidneys in pancreas donors. These are all low KDPI donors. There are some downsides, obviously, to pancreas transplant. It's a longer operation. A kidney surgery may be only 3 hours. A pancreas surgery may be more like 6 hours. There's also a longer recovery time, roughly double the recovery time when you're getting a pancreas transplant. Also, the pancreas transplant surgery involves surgery to your bowels, to your intestines. And so we sew the pancreas into the bowel, and then we need to let the bowel rest. And so you won't be eating anything for the first couple of days. When you wake up, you're going to have a tube down your nose into your stomach, and we're going to be sucking everything out so that we let the bowel rest and heal for a few days. So again, it's a more involved process, and it does require more immunosuppression as well, so higher levels of the medication that we give you. The other thing is, as I mentioned before, is that pancreas recipients have higher or stricter criteria than kidney recipients. So they generally need to be younger and healthier. Pancreas recipients need to be thinner by what we measure as the body mass index. For example, if your body mass index is under 40, we will consider you for a kidney. But to be considered for a pancreas, it really has to be under 33 to be considered, and really we like it to be below 30. They also have to have minimal vascular disease. The vessels on a pancreas are smaller, they're more susceptible to collapse, And so you may have some vascular disease that still allows us to do a kidney transplant, but too much to allow us to do a pancreas transplant. So that covers the various types of transplants that we do. I do want to talk something about the transplant evaluation timeline and what you should expect in going through the transplant process. The process will take you from initial evaluation through listing and to transplant. Initial evaluation is where we are today. You've come here, you're going to meet the team, we're going to find out about your medical history, and we're going to talk to you about what testing needs to be done. It's important to realize your evaluation today is not the same thing as being put on the wait list. We will do the evaluation today, we will then have you get some additional testing, and once all of that testing is complete, that is when we put you on the list and you start gaining time. Once you are on the list and gaining time, then we will still be following with you every year to make sure that everything is up to date with your testing, and also to make sure that nothing has changed in your medical history that would make it a problem for you to receive a kidney transplant. Okay? It's important to recognize that during this time, you may be asked to repeat some of the tests that you've done at initial evaluation, and that's because those tests are only good for a certain amount of time. For example, a cardiac test, a stress test, is generally good for 2 years. Okay, so every 2 years that you were on the wait list, we're going to ask you to repeat those cardiac tests. And other tests have different time that they are good for. Okay, if you have some medical problem during the time that you're listed and waiting for a transplant, we will inactivate you on the list. What inactive means is that you continue to gain time, so you continue to move up the list, but you would be passed over for any organ offer that happens while you are inactive. And if you then get better, we will reactivate you on the list and you will continue to gain time just as if you never were inactive in the first place. If we inactivate you and things continue, unfortunately, to decline, at that point, if we don't think things will get better, if we don't think it's safe for you to receive a transplant, we will then take you off the list. Eventually, with the list, we hope to get you to the point of actual transplant. When you get the transplant, you can expect that you'll have the surgery, you will be up and awake later that same day. We will get you out of bed within a day after the surgery. There's no sitting around in bed recovering for 4 or 5 days. You are generally in the hospital anywhere from 3 to 7 days. For living donor transplants, it's almost always just 3 days. Sometime, again, with the deceased donor kidneys that don't work immediately, where we need dialysis for a couple of days, the time in the hospital may be a little bit longer. When you go home, you're not going to feel totally normal. There's anesthesia in the body that has to be cleared out. But generally 4 to 6 weeks after the surgery, people are feeling pretty much back to themselves. In that first 4 to 6 weeks, people talk about having a diminished appetite, not so much energy, and difficulty sleeping. That's the most common complaints that we get. But again, by 4 to 6 weeks, those tend to clear. And then generally people feel ready to go back to work anywhere from 2 to 3 months after the transplant. So today's meeting, we said we're at the start, we're at the initial evaluation. You are going to meet the multidisciplinary team. We work as a group. We have a surgeon, we have a nephrologist, we have a financial coordinator because the medications after transplant can be expensive, and we want to make sure that you're not stuck with a surprise bill after transplant, because these medications can cost thousands of dollars per month if you don't have proper insurance. And we will work with you to try, if you have a problem with the insurance, to try and find a solution whereby we can go ahead and do the transplant. You'll meet with a registered dietitian, again, to talk about weight loss and where your weight lies and what is a healthy weight for you. You'll also meet with a transplant social worker who will talk to you about a number of things, including what is your support system. Nobody can go through a transplant on their own. Everybody needs a support person to help them out, driving them to and from appointments, helping them with medications, helping them if they're not feeling well. It absolutely is a critical part of the transplant team, is your support person who you have. And then on our end, the most important person, and the most important for you to know, is your transplant coordinator, who is a nurse here, who is going to be your primary point of contact. If you have questions, if you need to get us information, if you need information from us, she is going to be the person that you're going to rely on to get that. And if she can't give you the answer that you need, she will find the right person to get you the proper answer. What happens during this evaluation? Well, as I said, you're going to meet the team today. It's important for you to ask questions. There's no stupid question. There's no such thing as too many questions. I love when a patient asks me, do you mind if I ask you another question? Of course, you're always, that's what you are here for today, is to have your questions answered. Once we get to meet you as a team, we sit down as a team once a week and discuss all the cases for the week. We will discuss as a team whether you are a good candidate for transplant, and it'll either be determined at that point that we have enough information that we can accept you and list you for transplant, that we think you're a candidate but we still need to get some more information, so you'll be deferred until we get that testing, or we may decide that from what we've learned about you, that the risks of the surgery outweigh the benefits to you, and that we don't think that transplant is an option for you. And it's not the decision that anybody wants to hear, but it's important for us to be honest and upfront with you and not make things worse by getting a transplant. We never want to do that. We only want to improve your life and your situation by getting you a transplant. When you come out of here today, you'll have a list of tests that you need. You may get a call from your coordinator after the team meets if we decide that there are some additional tests that we want to get as well. Your timeline to keep in mind going forward is from the time you leave today, we want to get all of those appointments scheduled within 1 to 2 weeks. Not that you'll necessarily get all of those tests done, but you should at least have them on your schedule in your planner within the next 1 to 2 weeks. You'll have made those calls. We will be following up with you at 4 weeks to make sure and see where things are and try and help you with any sort of problems you may have encountered. But we really want all of the testing complete within 12 weeks. This testing you can get here at Georgetown University Hospital. You can certainly get it at another MedStar facility. You can also get these things done by your local provider. For example, if you have a GI provider and you need a colonoscopy, you may choose to get it at your local gastroenterologist rather than coming to a new doctor here at MedStar. That is perfectly all right. I will say that the first two options, getting it done here at Georgetown or at a MedStar facility, it's an easier, quicker transfer of results because we share a computer system. But absolutely, you can get your testing done at any place you choose. In general, the testing that we're going to ask for, we need to check your heart to make sure that there's going to be no problems with anesthesia. We're going to want to get a stress test for you. We're going to want to get an echocardiogram, that's an ultrasound of the heart, and we're going to want to get an EKG. We also want to screen for cancer, and this is the normal screening that you should be getting anyway, but a lot of people don't stay up to date on. But anybody who's over 45 is going to need a colonoscopy. For women, they need to have up-to-date pap smears and mammograms. For men, they need their prostate-specific antigen checked to make sure they don't have prostate cancer. And for anybody who's a long-term heavy smoker, we're also going to need to screen for lung cancer. In addition to those tests, there's blood testing. There's a lot of blood that we need to draw to check not only whether you have any viruses or infections or anything abnormal in your electrolytes, but also to check the individual proteins that are present so that when a kidney comes available, we can check whether or not you are a match with that kidney. So I want to take some time and I want to make sure that you all have a chance to answer questions, that you can ask them of your coordinators, you can ask them of the team when you see them. But I do want to touch on a couple of the more frequently asked questions that we get in transplant. And the most common one that I think we get is there's a lot of nervousness about the transplant medications, about the immunosuppressants that we use. People hear that there are a ton of medications and that they have terrible side effects and there's thousands of pills, and none of that is really true. It's absolutely true that the immunosuppressant, these powerful medications, are what keeps your immune system from attacking the new transplant. And you're going to take these medications for as long as you have the transplant. There's no point where it's going to be okay for that transplant, where that transplant will be able to live without taking the immunosuppressants. We do decrease the dose over time, but it never goes to zero. Typically, These are 2 medications, and typically you take them twice a day. Occasionally, we can use once a day medications, but generally think it's going to be 2 medications twice a day. I can't tell you the specific number of pills because everybody's dose is a little bit different, but usually it's a total of somewhere between 4 and 10 pills. But again, it's going to depend on the individual dose. Not only, though, do we add those 2 medications, we're taking away a number of medications. So for those of you who are on dialysis, a lot of you may be using phosphate binders, those big horse pills, the Renagel, the Savelomer, the Renvela, some of the others. You're going to be done with those. And usually I get a loud cheer at this point because those are kind of the worst pills to take. You're not going to generally need Aranesp or Procrit after you come off of dialysis. And there may be other medications, blood pressure medications, that we can reduce, and in some cases we can stop them completely. So yes, we do add on some medications, but we also take away several medications as well. Do these medications have side effects? They absolutely do, just like any medication can have side effects. The good news is that we have alternatives now. There are several different immunosuppressants that can be used, and if you have a problem with one, we will find a different one that works for you. What's really critical and what's really different about these medications and other medications you take is that you have to take these every day at the correct time. You can't miss doses. If you're taking a blood pressure medication now and you miss a dose, just take your next dose. You'll be fine. But that's not the case with the immunosuppressants. And the reason for that is I tell people, picture your immune system like a boulder, okay, at the top of a hill. If it never becomes activated, if it's just sitting there, your medication doesn't have to work that hard to keep it in place. This guy looks like he's working hard. He's not. That rock is sitting there. It's not going to move. He doesn't have to do much work. But if you forget to take those medications and the boulder starts rolling downhill, now you're this guy, right? Now you've got to not only stop it rolling downhill, but pushing it back up into a stable place. And simply going back on your usual medications may not be strong enough to stop that when it's already rolling. And sometimes we have to admit people to the hospital to give them really much more potent medication when they miss doses, and when that immune system starts rolling. That's what rejection really is that immune system starting to attack the kidney. So by missing doses, you may provide a window for that immune system to get rolling and need stronger medication to put it back into a quiescent, into a quiet, into a sleeping mode. So that's about immunosuppression. The other common question that I get is, what can I do as a patient to improve my outcome, to improve my chances of a transplant? Easy answer here. Number one, most important thing, if you smoke, if you use tobacco, stop smoking. Smoking, even smoking a little bit, has been associated with an 8 times higher risk of that graft, of that kidney failing, okay? Smoking also makes other diseases worse. It makes diabetes worse. It makes heart disease worse. It makes vascular disease worse. Do we require everybody to stop smoking before they get a transplant? Not necessarily. But when we're evaluating people, we're evaluating them as a whole. And so if you just smoke and don't have any other problems, maybe it's okay. But if you smoke and have diabetes, that's a bad combination. If you have heart disease and you smoke, that's a bad combination. If you have vascular disease and you smoke, that's a bad combination. And chances are, since we can't stop the diabetes and we can't stop the vascular disease, what we're going to tell you is if you continue to smoke, we don't think you're a good candidate for transplant. But even if we say we will let you get a transplant while smoking, you're still facing that 8 times higher risk of losing the kidney. So please stop smoking before we do the transplant. The second most important thing is to either maintain or to achieve a healthy weight. Surgical risk and diabetes risk both increase as your weight goes up. There is a weight, as I said, we go by the body mass index. Once you're above a body mass index of 40, we don't do the transplant. But even if you're below 40, even if your BMI is 37 or 38, weights that we might consider acceptable for transplant, if you lose more weight, your outcomes get better and your complications decrease. And so even if you come out today hearing that you are at a weight that allows us to do a transplant, unless you are at a healthy weight, which is generally considered a BMI of 30 or less, if you can lose further weight, that will make the transplant go much smoother. Some other things that you can do to improve outcomes or improve your ability to get a transplant: complete your testing promptly. We talked about having 12 weeks to do the testing, but really the faster we get you on the list, the faster you're gaining time. It's also one of the things that we pay attention to is your compliance, your willingness to do what we ask pre-transplant is an important consideration in post-transplant outcomes. We're going to look for people who are not following through with testing. Those are also patients who we get concerned about will not follow through with taking medications or seeing us for follow-up visits after the transplant, or all the things that make a transplant possible. The other thing to be aware of, as I mentioned before, is that tests are only good for so long. We've had some patients who they get their stress test and then it takes them more than 2 years to get their colonoscopy, and by the time they do their colonoscopy, it's time to repeat their stress test again. And then it takes them a while to get their stress test, and by the time that happens, they need to get their pap smear redone. And so they're in this vicious cycle where every time we're asking them for something more to do because it took them so long to get one test that another test has become outdated. So please, please, let's get your testing done promptly. It's less frustrating for you, and it works better for us. The other thing, and the last thing I'll tell people today, is be proactive. Make sure that we have accurate contact information for you. If your phone changes, if your address changes, please let us know about that immediately. Also, reach out to us if there are any changes in your medical status. Don't wait for us to kind of catch on to it. If you've had chest pain, if you've had a heart attack, if you've had things like that, let us get involved to fix and get you in a better place to receive a transplant, rather than calling you with an organ offer, finding out that you've just had chest pain and realizing that we can't give you that kidney because it wouldn't be safe. The last thing I tell people is that if you're concerned that something is needed, if you're concerned that you haven't heard from us in a little while, or you think that you were waiting for us to reach out and we didn't reach out, there may have been a miscommunication. Please call us. We've never gotten upset with people for calling too much. We do feel bad when people don't call and they were assuming that everything was okay, and we were assuming that they were doing stuff for us, and it was just a miscommunication that, again, slowed the ability to get a transplant. And that's what I wanted to say to you today. Thank you for listening. Please feel free to ask your coordinators, to ask your team any questions. This was really just meant to be an introduction to transplant. I'm sure that there are a lot of questions that can develop from this. So please feel free to reach out to the team, and I thank you for your attention.